Chapter 62, Mental Health Disorders. Priority concepts, mood and affect, and safety. Critical thinking. What should you do? A client is experiencing visual hallucinations. What should the nurse do? We'll answer this question at the end of the chapter. Okay, so anxiety. Anxiety is a normal response to stress, a subjective experience that includes feelings of apprehension, uneasiness, uncertainty, or dread. Occurs as a result of threats that may be misperceived or misinterpreted, or as a result of a threat to identify or self-esteem. Or as a result of a threat to identity or self-esteem. May result when values are threatened or preceding new experiences. Types of anxiety. Normal, a short-term, healthy type of anxiety. Acute, precipitated by imminent loss or change that threatens one's sense of security. Or chronic, anxiety that persists as a characteristic response to daily activity. Levels of anxiety. Mild, associated with the tension of everyday life. The individual is alert, the perceptual field is increased. Mild anxiety can be motivating, produce growth, enhance creativity, and increase learning. Moderate. The focus is on immediate concerns. Moderate anxiety narrows the perceptual field. Selective inattentiveness occurs. Learning and problem solving still occur. Severe anxiety is a feeling that something bad is about to happen. A significant narrowing in the perceptual field occurs. Focus is on 1 minute or scattered details. Focus is on minute or scattered details. All behavior is directed at relieving the anxiety. Learning and problem solving are not possible. The individual needs direction to focus. Panic. Panic is associated with dread and terror and a sense of impending doom. The personality is disorganized. The individual is unable to communicate or function effectively. Loss of rational thoughts with distorted perception occurs. Inability to concentrate occurs. If prolonged, panic can lead to exhaustion and death. Interventions. General nursing measures. You want to recognize the anxiety, establish trust, protect the client, do not criticize. Coping mechanisms. Do not criticize coping mechanisms. Do not criticize coping mechanisms. Do not force the client into situations that provoke anxiety. Modify the environment by setting limits or limiting interaction with others. Provide creative outlets. Provide activities that limit the amount of time for destructive behavior. Promote relaxation techniques such as breathing exercises or guided imagery. Monitor the vital signs and administer anti-anxiety medications as prescribed. The immediate nursing action for a client with anxiety is to decrease the stimuli in the environment and provide a calm and quiet environment. Priority nursing actions. Provide a calm environment, decrease environmental stimuli, and stay with the client. Ask the client to identify what and how he or she feels. Encourage the client to describe and discuss his or her feelings. Help the client identify the cause of the feelings if he or she is having difficulty doing so. Listen to the client for expressions of helplessness and hopelessness. Document the event, significant information, actions taken, and follow-up actions, and the client's response. If a client experiences anxiety, immediate actions are to provide a calm environment, decrease environmental stimuli, and stay with the client. Excess stimulation will escalate the anxiety. Next, asking the client to identify what and how she or she feels, and helping the client to identify the cause of the feelings helps to increase his or her awareness of the connection between behaviors and feelings. This awareness helps to decrease the anxiety. While listening to the client, the nurse observes for expressions of helplessness and hopelessness that could indicate self-harm intentions. The nurse provides follow-up care as needed based on observations and assessments. Finally, the nurse documents the event, significant information and actions taken, and follow-up actions in the client's response. Generalized anxiety disorder. Description: an unrealistic anxiety about everyday worries that persist over time and is not associated with another psychiatric or medical disorder. Physical symptoms occur. Data collection would be restlessness and inability to relax, episodes of trembling and shakiness, chronic muscular tension, dizziness, inability to concentrate, chronic fatigue and sleep problems, inability to recognize the connection between the anxiety and physical symptoms. Client is focused on the physical discomfort. Unexpected and expected panic attacks. Description: panic disorders produces a sudden onset of feelings of intense apprehension and dread. The cause usually cannot be identified. Severe, recurrent, intermittent anxiety attacks lasting 5 to 30 minutes occur. Data collection: choking sensation, labored breathing, pounding heart, chest pain, dizziness, nausea, diaphoresis, numbness or tingling of the extremities, a sense of unreality and helplessness, a fear of being trapped, a fear of dying. Interventions refer to Section 1, what we just went over. Post-traumatic stress disorder. After experiencing a psychologically traumatic event, the individual is prone to experience the event and have recurrent and intrusive dreams or flashbacks. Stressors like natural disaster, terrorist attack, combat experiences, accidents, rape, crime or violence, sexual, physical, or emotional abuse, re-experiencing the event as flashbacks. Data collection: emotional numbness, detachment, depression, anxiety, sleep disturbances and nightmares, flashbacks of the event, hypervigilance, guilt about surviving the event, poor concentration and avoidance of activities that trigger the memory of the event. (62.1) Interventions for PTSD. Be non-judgmental and supportive. Assure the client that his or her feelings and behaviors are normal reactions. Assist the client with recognizing the association between his or her feelings and behaviors and the trauma experience. Encourage the client to express his or her feelings. Provide individual therapy that addresses loss of control or anger issues. Assist the client with developing adaptive coping mechanisms and using relaxation techniques. Encourage the use of support groups. Facilitate a progressive review of the trauma experience. Encourage the client to establish and reestablish relationships. Inform the client that hypnotherapy or systemic desensitization may be used as a form of treatment. Clients dealing with cancer may develop post-traumatic stress. Cancer-related post-traumatic stress can occur anytime during or after treatment. The symptoms of PTS are similar to those of post-traumatic stress disorder, but are generally not as severe. Specific phobias. Irrational fear of an object or situation that persists, associated with panic level anxiety if the object, situation, or activity cannot be avoided. Types is box 62.2. Types of phobias: acrophobia, fear of heights; agoraphobia, fear of open spaces; astrophobia, fear of electrical storms; claustrophobia, fear of closed spaces. Hematophobia is fear of blood. Hydrophobia is fear of water. Monophobia, fear of being alone. Mysophobia, fear of dirt or germs. Nyctophobia, fear of darkness. Pyrophobia, fear of fires. Social phobia, fear of situations in which one might be embarrassed or criticized in the fear of making a fool of oneself. Xenophobia, fear of strangers, and zoophobia, fear of animals. Interventions is identify the basis of the anxiety. Allow the client to verbalize feelings about the anxiety-producing object or situation. Frequently talking about feared object is the first step in desensitization process. Teach relaxation techniques such as breathing exercises, muscle relaxation exercises, and visualization of pleasant situations. Promote desensitization by gradually introducing the individual to the feared object or situation in small doses. Always stay with the client experiencing anxiety to promote safety and security. Never force the client to have contact with the phobic object or situation. Obsessive compulsive related disorders. Obsessions, preoccupation with persistent intrusive thoughts and ideas. Compulsions, the performance of rituals or repetitive behaviors designed to prevent some event, divert unacceptable thoughts, and decrease anxiety. Obsessions and compulsions often occur together and can disrupt normal daily activities. Anxiety occurs when one resists obsessions. Anxiety occurs when one resists. Anxiety occurs when one resists obsessions or compulsions and from being powerless to resist the thoughts or rituals. Obsessive thoughts can involve issues of violence, aggression, sexual behavior, orderliness, or religion, and can uncontrollably interrupt conscious thoughts and the ability to function. Related disorders: hoarding disorder, excoriation, skin picking disorder, substance or medication-induced obsessive compulsive and related disorder, obsessive compulsive and related disorder as a result of another medical condition, trichotillomania, hair pulling disorder. Interventions in box 62.3. 62.3. I see interventions for obsessive compulsive disorder. You want to ensure that basic needs, food, rest, and grooming are met. Identify the situations that precipitate the compulsive behavior. Encourage the client to verbalize concerns and feelings. Be empathetic toward the client and be aware of his or her need to perform the compulsive behavior. Do not interrupt the compulsive behaviors unless they jeopardize the safety of others or the client. Provide for client safety related to the behavior. Allow time for the client to perform the compulsive behavior, but set limits on behaviors that may interfere with client's physical well-being to protect the client from physical harm. Implement a schedule for the client that distracts from the behaviors. Structure simple activities, games, or tasks for the client. Establish a written contract that will assist the client to decrease the frequency of compulsive behaviors gradually. Recognize and reinforce positive, non-ritualistic behaviors. Somatic symptom and related disorders. Description: somatic symptom disorders are characterized by persistent worry or complaints regarding physical illness without supporting physical findings. The client focuses on the physical signs and symptoms and is unable to control the signs and symptoms. The physical signs and symptoms increase with psychosocial stressors. The anxiety is redirected into somatic concern. The client may unconsciously use somatization for secondary gains such as increased attention and decreased responsibilities. Conversion disorder. functional neurological symptom disorder. Description: a physical symptom of a deficit suggesting loss or altered body function related to psychological conflict or a neurological disorder. Conversion disorder is an expression of a psychological conflict or need. The most common conversion symptoms are blindness, deafness, paralysis, and the inability to talk. Conversion disorder has no organic cause. Symptoms are beyond the conscious control of the client and are directly related to conflict. The development of physical symptoms reduces anxiety. Interventions: obtain a history and check for physical problems. Explore with the client the needs being met by the physical symptoms. Assist the client with identifying alternative ways of meeting needs. Assist the client with relating their feelings and conflicts to the physical symptoms. Convey understanding that the physical symptoms are real to the client. Assure the client that physical illness has been ruled out. Explore the source of anxiety and stimulate verbalization of anxiety. Encourage the use of relaxation techniques as the anxiety increases. Use a pain assessment scale if the client complains of pain, and implement pain reduction measures as required. Report and assess any new physical complaint. Encourage diversional activities, provide positive feedback, assist the client with recognizing his or her own feelings and emotions. Administer anti-anxiety medications if prescribed. For a client with a somatic symptom disorder, allow a specific time period for the client to discuss physical complaints because the client will feel less threatened if this behavior is limited rather than stopped completely. However, avoid responding with positive reinforcement about the physical complaints. Dissociative disorder. Dissociative disorder is a disruption in integrative functions of memory, consciousness, or identity. Dissociative disorder is associated with exposure to an extremely traumatic event. Dissociative identity disorder. Dissociative identity disorder, DID, formerly called multiple personality disorder. Two or more fully developed, distinct, and unique personalities exist within the person. The host is the primary personality, and the other personalities are referred to as alters. Alter personalities may take full control of the client, one at a time, and may or may not be aware of one another. The alters may be aware of the host, but the host is not usually aware of the alters. Dissociative amnesia. The inability to remember important personal information because it provokes anxiety. Memory impairment may range from partial to almost complete. The client may assume a new identity in a new environment, may drift from place to place, develop few relationships, then return home. Unable to remember the amnesia. Depersonalization, derealization disorder, an altered self-perception in which the client feels detached and one's own reality is temporarily lost or changed. Interventions: develop a trusting relationship with the client. Encourage verbal expression of painful experiences, anxieties, and concerns. Explore methods of coping. Identify sources of conflict. Focus on the client's strengths and skills. Orient the client. Implement stress reduction techniques. Plan for individual, group, and or family psychotherapy to integrate dissociated aspects of personality or memory and expand self-awareness. Mood disorders. Bipolar and related disorders. Description: bipolar disorder is characterized by episodes of mania and depression with periods of normal mood and activity in between. Interventions for mania: remove hazardous objects from the environment. This should be done for all clients. Monitor the client closely for fatigue. Provide frequent rest periods and monitor the client's sleep patterns. Use comfort measures to promote sleep. Provide a private room if possible. Encourage the client to ventilate feelings. Use calm, slow interactions. Help the client focus on one topic during the conversation. Ignore or distract the client from grandiose thinking. Present reality to the client. Present reality to the client. Do not argue with the client. Limit group activities and assess the client's tolerance level. Solitary activities may be necessary. Provide high-calorie finger foods and fluids. Supervise the client's choice of clothing. Reduce environmental stimuli. Set limits on inappropriate behaviors. Provide physical activities and outlets for tension. Avoid competitive games. Provide gross motor activities such as walking. Provide structured activities or one-to-one activities with the nurse. Provide simple and direct explanations for routine procedures. Supervise the administration of medications. Monitor for non-compliance. Depression. That's mood disorders. Bipolar and related disorders. Depressive disorders. Depression affects feelings, thoughts, and behaviors. It can occur after a loss, including loss of self-esteem, the end of a significant relationship, the death of a loved one, or a traumatic event. The loss is followed by grief and mourning. If this process does not resolve, depression results. Depression may be mild, moderate, or severe. Treatment includes counseling, antidepressant medication, and electroconvulsive therapy. Data collection for the person with depression is increased or decreased appetite, decrease in activities of daily living, decreased emotion and physical activity, easily fatigued, inability to make decisions, poor concentration, internalizing hostility, introverted personality, social isolation and withdrawn from groups, lack of energy, lack of initiative, lack of self-confidence, and low self-esteem, lack of sexual interest, psychomotor retardation, and suicidal thinking. For a client at risk for self-harm, ask the client directly, have you thought of hurting yourself? Electroconvulsive Therapy. ECT is an effective treatment for depression, not a cure. A small amount of electrical current is delivered through the electrodes attached to the temples that cause a brief seizure within the brain. Our movement is usually a slight movement of hands, feet, or toe because pre-medication is given to relax the muscles. In addition, a short-acting anesthetic is given. At-risk clients include clients with recent myocardial infarction, brain attack, or intracranial mass lesions. Pre-procedure. Explain a procedure to the client. Encourage the client to discuss feelings, including myths regarding ECT. Teach the client and family what to expect. Informed consent must be obtained when the voluntary clients are being treated. For involuntary clients, when informed consent cannot be obtained, permission may be obtained from the next of kin, although in some states the permission for ECT must be obtained from the court. ECT indications for use. When antidepressant medications have no effect, when there is a need for rapid definitive response, such as when a client is suicidal or homicidal. When the client is in extreme agitation or stupor. When the risk of other treatments outweigh the risk of ECT. When the client has a history of poor medication response, a history of good ECT response, or both. When the client prefers ECT as a treatment. Maintain nothing by mouth after midnight or at least 4 hours before treatment is prescribed. Baseline vital signs are taken. The client is requested to void. Hairpins, contact lenses, and dentures are removed. Administer pre-procedure medication as prescribed. During the procedure, as the IV line is inserted, electroencephalographic and electrocardiographic electrodes are attached. The blood pressure, pulse, and oxygen saturation are monitored throughout the treatment. A blood pressure cuff is placed around the ankle and inflated to block the medication from entering the foot. When the procedure begins, seizure activity can be monitored by watching for movement in that foot. Medications administered may include a short-acting anesthetic and a muscle relaxant. Oxygen is administered by face mask, and airway is placed to prevent biting the tongue. An electrical stimulus is administered. A brief seizure occurs. Post-procedure. The client is transported to a recovery room with the blood pressure cuff and oximeter in place, where oxygen, suction, and other emergency equipment are available. When the client is awake, talk to the client and take vital signs. The client may be confused. Provide frequent orientation, brief, distinct, and simple, and reassurance. The client returns to the nursing unit when at least a 90% oxygen sat level is maintained, vital signs are stable, and mental status is satisfactory. Check for a gag reflex before giving the client foods, fluids, or medication. Potential side effects include confusion, disorientation, and short-term memory loss. The client may be confused and disoriented when wakening. Other side effects include headache, hypotension, muscle soreness, nausea, and tachycardia. Memory deficits may occur, but memory usually recovers completely, although some clients have memory loss lasting 6 months. Monitor both a depressed client and a client who has recently been prescribed an antidepressant medication closely for signs of suicidal ideation. If the client presents with increased energy, monitor closely because it could mean that the client now has the energy to perform the suicide act. Schizophrenia. Schizophrenia is a group of mental disorders characterized by psychotic features, hallucinations and delusions, disordered thought processes, and disrupted interpersonal relationships. Disturbances in affect mood, behavior, and thought processes occur. Treatment with medication controls symptoms associated with the disorder. Data collection. Physical characteristics: unkempt appearance, may neglect hygiene, eating, sleeping, and elimination. Body image distortions. May be preoccupied with somatic complaints. Motor activity. Catatonic posturing, holding bizarre postures for long periods. Catatonic excitement, moving excitedly with no environmental stimuli present. Waxy flexibility, having one's arms or legs placed in a certain position and holding that same position for hours. Possible total immobilization, inability to respond to commands or responding only to commands. Echolalia, repeating the speech of other person. Repetitive or stereotyped movements. Echopraxia, repeating the movements of another person. Motor activity that may be increased as evidenced by agitation, pacing, inability to sleep, loss of appetite and weight, and impulsiveness. Possible inability to initiate activity, inertia. Emotional characteristics, mistrust may be present. View of the world as threatening and unsafe. Affect may be blunted, flat, or inappropriate. May display feelings of ambivalence, helplessness, anxiety, anger, guilt, or depression in response to hallucinations, delusions, or as a result of the grief related to losses imposed by this illness. Compulsive rituals, performed as an attempt to solve conflicting feelings by constant repetitive activity. Overcompliance, attempt to deny responsibility for any action by doing only what another instructs exactly. Affective disturbances, flat or incongruent affect or inappropriate affect. Altered thought processes, abnormal thought processes, types of delusions,